So my name is Darren Kies. I'm an interventional radiologist and diagnostic radiologist for Piedmont South Imaging. There is definitely a role for percutaneous ablation of colorectal metastases to the liver. Backing up a little bit, when you're talking about patients that have liver-only metastatic disease from colon cancer, it's well established that the best options they can have is surgical resection. So if they are a surgical candidate, if the disease is limited to one lobe of the liver and they can have a hepatectomy, then that is the best option for them. However, there are cases in which perhaps there is dominant disease on the right and one small lesion on the left. Those are cases where you can use percutaneous ablation to basically assist with a surgical resection and have very equivalent survival outcomes. Now, if patients are not surgical candidates for resection of their colorectal liver metastases, there is a way that they can be bridged or downstaged to a resection using other local regional therapies. And it really just depends on where the tumor is located and what the sizes are. Sometimes that includes liver ablation. Sometimes it includes Y90 radioembolization. Sometimes it includes chemoembolization. Sometimes it includes other local therapies such as SBRT. But if you can get a patient to the point where they are candidates for surgical resection, that is certainly going to improve their survival. Now, if you're talking about patients that aren't surgical resection candidates, so they have diffuse metastatic disease, or maybe they have extrahepatic disease as well, that's evident. Is there a role for ablating their liver metastases? Whether it's going to improve, in patients with extrahepatic disease, whether it's going to improve their survival is somewhat debatable. And some of it depends on how heavy of a burden of colorectal metastatic disease they have and where these tumors are located. The liver is a vital organ. And liver failure is something that unfortunately has a mortality associated with it. So there is a role for using local therapy in patients with liver dominant disease, even if there are a few extrahepatic lymph nodes or maybe a pulmonary nodule here or there. Whether you decide to use ablation is certainly going to depend on where the tumor is located. If you have an isolated focal hepatic metastasis that's in a safe place to ablate and it's less than 3 centimeters in size, I think ablation is great for liver metastatic disease. One thing that interventional radiologists, interventional oncologists have to keep in mind for liver metastases is that your margins need to be adequate to make sure you treat the tumor effectively. For hepatocellular cancer or for renal cancer, it's generally a more encapsulated tumor that you're targeting, especially when they're small. And the margins that are generally accepted are somewhere around 0.5 centimeters. For metastatic disease, usually these tumors are much more irregularly shaped. They're not nice round lesions. They don't have an identifiable capsule. And you want to have at least a centimeter margin of ablation around your tumor to ensure a good local control rate. So sometimes knowing that you need that margin does affect the number of tumors that you can treat or the size. Now, in patients that have multiple liver metastases that are all small, most people keep a number of 5 in their head. You can ablate up to about 5 spots in the liver, but once you get above that, it just becomes, then you're looking at other therapies. If a patient has 10 to 12 liver metastases, it just doesn't make sense to treat all of those focally with an ablative type strategy. Those are scenarios where you'd probably tend towards something like radioembolization or chemoembolization to try to treat those tumors. But certainly if it's 3 to 5 tumors, they're all ablatable, they're small size, I think this certainly is beneficial for patients and something that should be considered.